Dr. Kasper, how are you?
I'm doing well. Thank you. Thank you for having me.
Absolutely. I actually was sent your article in The Atlantic, or the article that featured you in The Atlantic, by multiple people. I had Susie Keller, the CEO of the Medical Association, in recently, and asked her, I said, hey, look, I don't understand what's happening. Can you recommend somebody who I could talk to, perhaps who's an actual medical professional that could help me out? And she's like, oh yeah, get a hold of this Dr. Katz. And she sent me the link too. I'm like, oh, I've gotten this Atlantic article before. So you are an OB/GYN in Nampa. You deal with pregnant ladies all the time and ladies in general. You have testified at the state legislature. You've done a lot concerning women's reproductive care. Yeah. You also happen to be pro-life and to some degree faith-driven. I appreciate that. This is a difficult one, right? If you don't mind, could you give me some background on where you are, how you've come to this point? You've obviously been practicing here for some time. Talk to me about it all.
So that's a big, broad question. I trained, went to medical school in Oregon, did my OB/GYN residency in New Mexico. I have never done pregnancy terminations, ever. And that, with my training, there was different levels of acceptability to that, perspective. When I trained in New Mexico, it's actually a big abortion training program, and they would sit us all down near the beginning of our residency and give us a speech on, why they felt like abortion training was important, and then would give us the option of it was part of the curriculum, and if we decided that was not something we wanted to participate in, we could opt out. And so that's what we called it in my program. Oh, she's an opt-outer. So we would sometimes switch responsive, like I would go cover labor and delivery while someone else did a case that was
an
opt-out case. Yeah, exactly. And then there were also things that went the other way. So if there was say a 19-week fetal demise that we were doing a procedure for to resolve that pregnancy, I would have my colleagues would let me go do that one because we all felt that it was important for us to get good training. And so that was a case where the baby had already died. And so I remember at least once or twice that someone would step aside and let me go do that case. So this has been I've had many, many years in training and in practice of practicing full spectrum obstetrics and gynecology without doing elective terminations.
So and again, to be clear, you're not a fan of elective terminations. It's not something you do. It's not something you engage in during medical school. It's not something, the whole bit. But we're not here today because you love the reproductive laws that are in place in Idaho. And we're not here and I'm sitting across from you saying, I do not like elective termination. I don't like abortion as a birth control. I don't like it for whatever reason, you don't like it. But there are still problems with this state's laws.
Correct. Idaho has some of the most extreme anti-abortion laws in the country. They are laws that were written without input from the medical community, or at least very, very little. And they were written at a time when no one, it's an interesting history because they were written at a time when no one expected them to be law, right? They were written during a Roe v. Wade world. And so it didn't, in a certain respect, there was a perspective that it wasn't super necessary to spend a whole lot of time on getting all the details and nuances right, to think through, possible unintended consequences, because it was really just a statement on the books of the pro-life stance of the government in Idaho at that time. And then when the Dobbs decision came, all of a sudden, this law that had been unconstitutional and invalid prior overnight became an actual law. So now you have this law on the books and a whole bunch of people coming forward and saying, hang on, this is now a problem in terms of how we deliver medical care, how we keep women safe, how we take appropriate and safe care of pregnant women. But somebody has to admit that it needs to be changed. And that's been a very steep hill to climb, as it turns out.
Okay. When the trigger law went into effect in 22, it's my understanding, again, please correct me if I'm getting this wrong, but it's my understanding that when the trigger law went into effect, there were no exemptions. There was no exemption for life of the mother. There was no exemption for, no.
No, there were. So life of the mother.
Affirmative defense or exemptions,
right.
proper exemptions.
Yeah. So the whole exemption, that is correct. Whether you call them an actual exemption or an affirmative defense opportunity for getting out of trouble, that is a fair statement. And I'm not an attorney. I don't
Great. Let's skip that part.
Understand all the implications of that.
Let's jump to the session in 2023, the legislative session. The Medical Association is meeting every day with a pro-life advocate, hashing out legislation. They form legislation that says we have exemptions, proper exemptions for life of the mother. Everybody understands that. We have exemptions for rape and incest in the absence of police reports. And there's a large argument around this, obviously, because the question is, okay,
Absolutely.
if you have somebody who is potentially like raped by their uncle or their father or something like that, and it comes to pass that they're pregnant. I mean, all of these bad things in general. There are also reports from law enforcement that in events like this, it is not, you should not assume that the remaining family members will be sympathetic to the young woman. There are plenty of cases where a horrible tragedy has befallen a young woman at the hands of an older relative, and the young woman is blamed for these things. So when I first heard that, I was like, well, why not have a medical, or why not have a police report? And then somebody explained it's like, okay, I'm not saying it's right or wrong, but like I get your argument. So again, you had life of the mother, you have rape and incest with no police report, and then you had health and welfare of the mother. That was an agreement that was hashed out with a medical association and the pro-life individual. And before it hit the floor, it was effectively harpooned by, I'm not 100% sure who sent out an email, but there was an email sent out to all the legislators saying, hey, this is a really, 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 really bad thing. And different legislation was brought forth. The legislation that ultimately passed in 2023 said, hey, life of the mother, 100%, rape and incest with an expedited police report. Okay. No exemption for health and welfare of the mother.
Correct.
So hearing that, it's like, okay, so the real sticker, like, because again, I understand police report, non-police report. I understand there's a debate here and discussion and should be robust and clear, especially when you're dealing with something as severe as this. Fine. And again, I don't know what the right answer is. But the real stickler was health and welfare. That's the big piece where people, it's been expressed to me that that's the big piece that people object to strongly. And you have some people on one side saying, yeah, but you could say like a headache's your health and welfare and then get a termination. And you have other people on the other end of the spectrum saying, you can have horrible things happen to you that don't lead to your demise, like organ failure, loss of reproductive capacity, all of these things that we think should be taken into consideration. That's the stickler, it sounds like, for a lot of people, which is there's a world here where we're not talking about you necessarily dying, but you surviving and there being really bad permanent stuff. Help me understand this, especially somebody who does not like elective pregnancy termination.
Yeah, so I think one of the, and we can talk about some specific potential, specific examples, but I think to sort of set this up, healthcare in developed countries, we don't run around, quote unquote, saving lives. Okay, we do, but now we have the ability to interrupt a health problem miles and miles before it gets to life-threatening, right? So And I think that's where some of this stuff becomes a little bit difficult to talk about. Because if you were to ask me if today, this morning in my office, when I was seeing patients, did I save anyone's life? And my first response would be no. I mean, I didn't see anybody super sick today. I didn't. But you could make an argument that's not really true, right? Because I was talking to, for example, I had a conversation with one young patient about a thing that she has going on that is fine right now. But if we do nothing about it, it does put her at risk of certain kinds of cancer 30 years in the future, right? And so you could argue that me having that conversation with her now so that she understands why we're recommending hormone therapy for her now is not just because we like to throw birth control pills at everybody, but because there is this very real risk of certain cancers 30, 40 years down the road. And you could argue that I might be saving her life from cancer in 40 years by having the conversation today. But that's the place that we're in healthcare in a developed country like the United States, is that's where we take care of women. Can we take care of cancer? Can we treat cancer? Yep. But you know what is better than treating cancer? Preventing cancer. And so that's what we want to do. So when we're talking about pregnancy complications, to say, oh, well, the point is we want to prevent the death of the mother. All right, that's a great goal. The problem is that when you say it that way, the question then becomes, what does that mean? Does that mean I know for sure she's going to die? Does that mean I know she's for sure going to die in the next 24 hours? Does that mean she has a possibility of dying? And where is our line that's acceptable, right? So the maternal mortality in the United States right now is like 40 in the realm of, and I may misquote the exact number, but it's in the range of like 40 women out of 100,000 pregnant women is maternal mortality in the United States right now. So that is, what does that calculate out to? 0.0004%.
Yeah, sure.
Right. So if that's the maternal mortality that we have in the United States, what mortality risk, right? Because I don't have a crystal ball. I have this conversation with my patients all the time. I don't have a crystal ball. So I can say something is very, very dangerous. Can I tell you 100% you're going to die or your baby's going to die if we don't intervene? I can't tell you that because you might survive. But I can tell you your risk is very high of something bad happening. So, if we're talking about mortality risks, then like what's acceptable? If our baseline risk is 0.0004%, are we okay with a 50% mortality risk? Like for me to say, no, I can't tell you 100% for sure that this will result in the death of the mother, but it's a 40% risk of mortality. Like I can tell you that the most conservative family I take care of is not going to be comfortable with a 40% mortality risk for their wife and mother of, let's say 3 or 4 other children, right? That's not going to be a comfortable place for them. But the way the law's written, there's no, it really is kind of written as a 100% mortality risk. Like that's not how we do medical care. The other problem is that if we...
if I may ask, I apologize. There are instances where you could have like an ectopic pregnancy that is like 100% fatal to the mom, right? Or are there situations where you have like 99.9% mortality if left unchecked? Or is it even like, hey, look, even in that case, like it's possible that she would survive. She would just obviously have, significant organ damage, loss of capacity to bear children, things of that nature.
Sure. That you can get close to that with some maternal heart conditions. You can get close to that with, like let's say chorioamnionitis, so an infection of the uterus that can happen after pre-prom. Like that's the mortality risk for that is very, very high. And there's pretty much universal consensus that qualifies as preventing the death of the mother to intervene in that situation. So so you can get close to that. But the problem in medicine is that we all have story, right? We can all share stories of that one miracle patient where something happened in a good way that we didn't expect. And that's one of the amazing things about medicine is getting to experience those things. That doesn't mean that we go run around willy-nilly, just not treating people because, well, you might, I mean, that's insane, right?
So as of right now, we have qualified situations where everybody agrees, okay, this has a high probability or passes a threshold of probability for being life-threatening to this mother, and we then accept that. So it's not like hey, we know 100%. It's like, no, essentially you cross this threshold of probability, and then we're justified in taking this particular action.
Sure, yeah.
So even with the life of the mother, there's no like black and white. It's no. You cross a 60% probability threshold or 70% probability threshold. Yeah, you got a 30% chance that you're going to survive, 70% chance that you're not going to. So we are going to take the appropriate action, with your consent and everything.
Right.
But like, that's not a point where people are like, okay, but you took that course of action because there's 100% guarantee that this person was going to. It's like, no. We already bake into this law a game of probabilities.
Yeah. And in the case of a uterine infection, right? It might be that she goes into labor and passes the baby and the placenta and clears out all the infected tissue, and we're given broad spectrum antibiotics, and maybe she gets through that without us actually terminating the pregnancy. Maybe, right? But if that's a 2% chance that it's going to end up that way, no one's going to take that risk.
That's it. Thank you for explaining this to me, because I have been operating even up until the last 45 seconds under the assumption that the life of the mother designation are these 100% guaranteed situations where there's no chance you're, holding your breath for an hour, right? Like, no. Nobody's ever done it. Nobody's going to do it. No, there's not even like a miracle case. But that's not the case. That's not what we're dealing with. We're dealing with probabilities.
There's always a miracle case. I mean, the only thing where it's 100% is their heart stopped,
sure,
right? And so you're coding them. And in medicine, we have a tendency to think of those sort of things as saving someone's life. We tend to not think about those, 40-year in the future cancer prevention conversations. But but even those cases, right? I'm sure you can find stories of someone whose heart has stopped and there was no one to give them CPR and their heart stopped, and whether that's actually what happened or not. Like you can always dig up these miracle stories, and those are wonderful, but that is not how we conduct our lives, taking care of the human being like you in front of me that is important and valuable, and I need to keep you safe.
So when we're talking about the exemption for life of mother, there's a broad spectrum of situations where we assess the probability of being past a certain threshold, and then we tolerate a certain action. But underneath that threshold of mortality, there's another gray area of damage, really risky. And again, I do not know the nuances of these things, but just in the brief understanding, it's like, you have things like you're going to lose a kidney, or you're going to lose, all kinds of things. How do we flush these out? Like, what could you give me some examples of these where it's like, okay, this is a situation where this will happen, or this is a situation where this will happen?
So,
or just pretend like I'm the most staunchly pro-life person ever, and I'm like, justify to me or explain to me what the situation is that should be considered outside of the life of the mother that I should take into consideration.
Sure. Let's say, so this came up the other day, previable severe preeclampsia. So preeclampsia is a condition where the pregnant woman, it only occurs in pregnancy. Pregnant women's blood pressure goes up. And with severe features, there can be end organ damage. It's one of the top maternal mortality causes, culprits in the U.S. And related to stroke and other things. Well, if you have, it very rarely, so, and maybe that's another thing to say too, is, these things happen on a consistent basis, but we're not talking about large numbers of women, right? Like we're not talking about, oh, there are another 3,000 abortions that would be done in Idaho every year if
we allowed
if we allowed for a health exception, right? Sure. I mean, these are statistically, these are small, fortunately, unusual things to come up. But as doctors, it's our job to take care of them. So we see them on a consistent basis. So severe preeclampsia with severe features happening before fetal viability, which is somewhere, 22 weeks is kind of the limit of where we see that. So, if you have preeclampsia with severe features at 20 weeks, all right, so then what do you do there? Do you try to control her blood pressure and get her to fetal viability? You can do that. And that's the first thing that we try to do in any woman who has preeclampsia with severe features, is that we have tons of medical science around stabilizing that and prolonging the pregnancy as far as we can get it. What if our treatments are ineffective? Kidney damage is something that can happen with preeclampsia. Usually is reversible, but isn't necessarily completely reversible. And so if you're at 20 weeks, you're having trouble stabilizing that woman. She's not quite to the point where you're worried about a stroke that could kill her, but you're starting to see kidney dysfunction. Like, where is your line where you say, all right, we're going to let you fry your kidney and see if we can get you farther? Recognizing that, again, the uncertainty goes both ways, right? You have no guarantee that you're going to get her far enough along safely, or, without truly putting her life at risk for that baby to make it. That baby's risk of a fetal demise before you get there is really significant. There is no guarantee that that baby is going to survive. And even if you can get to fetal viability, there is no guarantee that that baby is going to ultimately survive resuscitation and all of the care that's needed for an extreme preemie. So being in a situation where you have no ability then to take that specific situation, what's going on with that specific woman, how sick she is in some respects but not others, and you just have no ability to do anything until you can say, okay, she's having a stroke now. So now, we're not going to effectively treat this stroke while she's still pregnant. We got to terminate the pregnancy. That's a very difficult place to be in, and a good example of a place where, if we're pushing it until there's some kind of really strong, clear, life-threatening event, we're not going to be able to pull all those women back, right? If we're pushing it to the brink, statistically, we're going to lose some of those off the edge of the cliff.
Like in your stroke example.
Yeah.
Like if somebody's having a stroke, there's no guarantee that they're coming back.
No, especially not with the strokes that are related to preeclampsia. So it is my job as a doctor to keep patients in as safe a zone as I can. And when they're getting close to that danger zone, we're doing things. And the majority of the time, that does not involve terminating a pregnancy. But sometimes that's going to be a thing that pops up. And it puts us as physicians in a very weird place where it's not clear like it used to be. Like, oh, this is in the woman's bed. Like, this is going to end badly. I can intervene. The other thing that kind of makes me crazy is this whole concept that for a pre-viable fetus, you have the option to choose between the life or even the health of the mother and the life of the fetus, right? Because by definition, a pre-viable fetus, and when I say pre-viable, I mean a baby that is too early in gestation to survive outside the womb, even with our best medical care. A pre-viable baby whose mother dies, by definition dies, right? So there's no choice here. And the way it gets talked about is very much like there is a choice, and there's not. You cannot have a pre-viable unborn baby survive without a mother to carry that baby who's healthy enough to keep that baby alive until the gestational age of fetal viability.
Taking this into account, again, we're talking about a low number of these situations, right? It's not like, 50 out of 100 pregnancies or even like 1 out of 100 pregnancies. You're talking about a much smaller number of people that it sounds like you have a very clearly defined, at least in this metric, like, look, this is one thing that could end in stroke. It could be terrible, like organ loss, all of these things. What are the other things? Because this, again, to me, it's like, okay, well, that seems pretty terrible. And it makes sense why you would say, hey, I am a pro-life physician, but I see a need to have more clarity or, like this needs to be included in the exemption, right? What are the other things? Because this is a really clear one. At least it seems clear to me. What are the other things that are included? Because I've had a lot of people articulate, they're like, oh, well, so like, what, you're in a bad mood, like you have like a mental breakdown, you're just upset about these things. It's like, okay, well, look, I don't know, because I wasn't involved in the conversations with all this stuff. Like, I'm an idiot. So I don't, what are those other things? Because people always go to the extreme of like, you're gaining weight and you feel like that's bad for your mental health, so you want to terminate the baby. It's like, I don't think people are saying that, right? Like that doesn't, right. And again, I wasn't there, maybe they were, but that doesn't seem right. Like it would make a lot of sense. So this being one example, if you could, what's another example of something that people would need to understand? It's like, hey, look, this is a possibility.
So PPROM is one of the preterm premature rupture membranes is one of the examples that gets used a lot. If a woman's water breaks, say at 16 weeks, that is not going to end well the vast majority of the time. There are individual examples of women who are able to carry, and there are protocol, very strict ones that would allow us to monitor that. But it's also, you're talking about a single-digit percentage chance that the baby's going to survive. So, and you're talking about a vast majority of these, if you do no intervention, will develop a life-threatening uterine infection.
Okay. I was just going to say, look, I'll take, if my wife's pregnant, like I'll take a single digit versus no digit, right? But that's not the trade-off. It's like, no, single digit for the baby. And then for the mother, you have a non-zero significant probability that you could develop a life-threatening, not guaranteed, but a life-threatening illness infection.
Right. So taking away the ability to look at that. And then here's the other problem is that all of these situations, because they are rare, these are the hardest things that we deal with in medicine, right? These are not the straightforward, you just apply this protocol and this is what we go do.
Sure.
These are some of the most challenging, difficult, complicated situations that we deal with in obstetrics. There's an infinite number of variables all the time. Infinite number. And so to take away the ability to sit down with somebody and say, okay, this is what's going on, here's the numbers. Here's the, what do you want to do? To take away the ability to do that is a very that's a very nerve-wracking, scary position to put physicians in and healthcare providers in who are dealing with these very high stakes situations.
How do you mean?
So, I mean, people could, you know, you go to work every day. If you mess up, what happens?
Well, I mean, I look like an idiot pretty much like I do every day.
So if I go to work,
that's it.
So every day,
Right.
every day, if I go to work, if I mess up, somebody could die. This is what all of us live with. This is the level of intensity that all of us have every day when we go to work, right? And we learn to manage it. We all learn to manage it. But that's our baseline. That's when things are good, right? And so you take that and then you take okay, if I mess up, somebody could die. But then on top of that, I now have this whole spectrum of ability to take care of and manage these pregnancy complications that has been removed from me. So now I have half of what I had before to use to keep women safe, keep them from getting close to dying, because that's my goal. I don't want to let somebody go to the brink of death and then rush in and save them. That's, kind of a toxic hero mentality, right? We don't want to do that. And that ends up, and, we haven't brought up the whole issue with physicians leaving the state, not coming to the state, but that creates a level of intensity that is intolerable for many people. Because it's not just, we're just gonna not do, we're not sitting on the sidewalk holding picket signs. Or not. Like, that's not what we're talking about. We're talking about a real human being who has a really significant pregnancy complication going on. And we have to decide, is this close enough to being is this life-threatening right now that I can justify doing this and hope I don't get in trouble for it? Or are we not quite there yet? And so I have to sit on something that I feel is unsafe because I gotta let it get closer to life-threatening. This is a early PPROM, 16 weeks, and baby's alive. Mom doesn't have any signs of an infection yet, but, by the way, she's on some kind of medication that makes her immunosuppressed. Or, when I did her exam, her cervix was dilated, which increases her infection risk. Now all of us, in the past, it was like, I know this is not going to end well. Like, I can talk about statistics, but I'm looking at you as an individual and what you have going on, and I'm here to tell you this is not going to end well. So let's take care of it now. When we don't have an infection, you're not going to be in the ICU on pressors for 3 days while we treat your overwhelming sepsis because we waited too long. Let's take care of it now, right? No infection, carry you through it, get you through it without needing a blood transfusion.
And by the way, if you don't want to, you don't have to. If you're asking for my statistical analysis of this, I would take this course of action.
Right.
If you want to shoot for it, shoot for it.
And that is always any human's prerogative. I mean, we have laws in this state. You have to consent to whatever treatment is there. And so if you say, cool story, I hear what you're saying, I don't want to intervene. Great. Let's talk through alternatives. I'm right here. You change your mind. We're going to do our best to take care of you outside of that. But I've been clear. We have all the options there, and we're going to take this one step at a time.
you brought up the physicians leaving and then physicians not coming in. My concern in this entire conversation is understanding what the problems are as seen by the populace and seen by the medical establishment, and finding a way to reconcile those with the end result of having as much and as robust a medical care system for the Idaho women as possible, right? And obviously OBs and GYNs are very closely tied together and usually the same person. And if one of them, if a person leaves because they're like, I don't want to practice, OB here, then the GYN goes as well because they're the same person.
Right.
And that's not great. So for people that are like 50 or 60 or 70 or people that are younger, that are not engaged in making babies, that's a problem for them. Right. And for our mothers that are high risk and do need extra care, that's a problem for them as well. And just mothers in general. So that's what really motivated me to come into this conversation and say, okay, what's the disconnect here? Like, what is happening? And in talking to Susie Keller, the CEO of the Idaho Medical Association, she articulated, look, after Roe versus Wade was repealed and the trigger law went into effect, fall of 22 to the fall of 23, the state of Idaho lost 25% of its OBGYNs. And I put that clip out onto the interwebs as I do, and people lost their minds saying, hey, one, that's a total lie. Two, they left because of low pay. And the total lie, it's like, okay, where are you getting your data? And nobody ever responds.
Yep.
And this is the CEO of the person who represents the medical practitioners in the state. Okay, fine, but be that as it may, they left because of low pay. It's like, well, did we drop the pay all of a sudden in the fall of 22 to motivate people out? Or another person said that the market is responding to market forces and there aren't that many people having kids or aren't enough people having kids in the state to warrant the supply of doctors we have. It's like, okay, I think that our state is growing faster than it ever has. That didn't seem to make sense. But be that as it may, it's like, I don't know. Because and they're like, how do you know? It's like, oh, me? No, I don't know. Like, I don't know any of this stuff. And by the way, this clip is not of me saying this. This is what she's reporting. Right. You are an OBGYN in the state of Idaho. What has been your experience and your colleagues' experience since fall of 22?
So we've had a definite decline in the number of OBGYNs. So let me set this up too, okay? Idaho, in terms of workforce, and that we just don't need as many doctors as we have, and that's why people are leaving. Idaho, for the last number of years, has ranked between number 47 and 50 in the 50 states of the number of physicians per capita. Okay, we are at the bottom, and I don't have population numbers in front of me, but I feel like it's fairly common knowledge that the population of Idaho has grown dramatically in the last 10 years. I've never said that and had anyone argue with me that that's not in fact happening. And the population of doctors, interestingly, has not. And, we all know that Idaho is a magical place to live. So if physicians aren't coming here in the same numbers that the non-physician population is coming here, I think that's a very reasonable question to ask. Number one, why is that? And then with OBGYN specifically, so we've had this offset, huge population growth. We started off not doing well in physicians per capita. And then we also know that the number of physicians has not increased with the proportionately to the population increase. Then we had 2022 happen. And one of my favorite concepts in science is a chemical principle called the Chatelier's principle. And it is applied to chemical reactions. It is the principle that when you apply pressure to a system, that system will shift away from that pressure. So in...
like a balloon.
Yeah. So like in chemistry, if you have a chemical reaction that produces heat, if you apply heat to, if you have a chemical reaction that requires heat to run, if you heat up that chemical reaction, it'll run faster, right? Because you're supplying one of the things that it needs. Conversely, if it produces heat, and you heat up that system, it's actually going to run slower because it's pushing against, you've already made it kind of hot in there. And so it's going to push against that. And it's a principle that applies to all of life. Okay. You apply pressure to a situation, you're going to have that situation shift in a way that relieves that pressure. And so what you see happening with the workforce here, you have some OBGYNs and maternal fetal medicine physicians who have left the state specifically because of the laws. And going back to what I'm saying about our baseline intensity for our job every day is I come to work and mess up, somebody could die. That is my baseline job intensity. And then you've added more intensity and anxiety on top of that. And so, you hear stories from these physicians who say, I was developing panic attacks when I had to be on call because I'm like, is this the night that I'm not going to be able to intervene and somebody's going to get too far before I can intervene and something really bad's going to happen. So we lost some physicians for that, but then there are also physicians who are always leaving, right? So there's physicians who are leaving because, they're moving to somewhere else to be closer to family. You're always going to lose physicians to retirement. Like that happens in all professions, not unique to medicine. And then what happens is that we can't recruit. It's become very, very difficult to recruit OBGYNs to come to Idaho because you can take the most pro-life OBGYN who is thinking about moving to Idaho. Either they just finished training or they've got a job, they're thinking, I want to move somewhere else. And they look at Idaho and they say, well, boy, I could go there and I'm going to have to think about being on call and whether or not I can intervene with a pregnancy complication. Or I could go to this other state and never have to think about it. And what are they going to do? Right?
And the other state may not, there's not a requirement. So for instance, say this person moves to like Oregon and she's like, hey, I'm not into elective abortions. I will not perform them. They cannot force this person to perform those things.
No.
Not she or he, but this physician just gets to say like, hey, I have my standards. And perhaps Idaho mirrors my position with not wanting elective abortions as part of the birth control mechanism, just elective birth control. I like that aspect of Idaho, but Idaho also puts me in a precarious situation where I may have to defend with my freedom and my license and everything else, my decisions, even though I'm pro-life and I'm definitely not going to do something that goes against my principles, but I may be put in a position in Idaho where I have to defend myself intensely in that regard. So I'm just going to go somewhere else.
Right. And let's not forget that Idaho's not the only conservative state out there, right? Like maybe that person doesn't choose to go to Oregon or Washington. Maybe that person says, I can just go across the border to Utah and I get to live and work in a conservative environment that's attractive to me. And I don't have to worry about that stuff.
Understood. So the idea then is like, hey, I'm going to take lifestyle and conservative community values into consideration. And if choosing between Idaho and Utah, I get similar conservative values and a similar community lifestyle, but I also don't have to worry about this additional strain here. So even though this person was never here and never practicing, this is a consideration when people are thinking about, should I move to Utah or Idaho?
Sure. So, that's an example, but you have that Le Chatelier's principle that if that's one more factor, right, it's one more factor that's going to push physicians away from choosing to come here. So we've not been able to replace the physicians that we've lost. Whether or not those physicians are leaving specifically because of the law or for other reasons or for retirement, like it doesn't really matter at the end of the day, right?
Well, it would matter if I may, it would matter in that we look at a solution differently. Like let's say we did lose 25%. Okay. Let's say that Susie Keller is accurate on her numbers, just for argument's sake. If we only lost 1% of those because of the law and we lost 24% of those because of retirement, then we say, okay, then the law isn't necessarily the issue. The issue is more that we have a bunch of old people and we have to figure out how to attract more people. As opposed to we lost 0 to retirement, we lost 25% because of the law.
Sure. But I would also submit that at the end of the day, it doesn't really matter if you lose them to retirement or to the law.
Because we need to replace them.
Because you have to replace them. And so if you can't replace them because of the law,
right.
You can argue it forever, and it's a straw man argument.
We
It
both
doesn't
have
really matter.
to stop people from leaving if they're leaving because of the law. And in a separate note, we have to figure out what would attract more people here to replace either the retired or the departed.
Right.
And so that's why it's like, look, it doesn't matter. If we lose 25%, we lost 25%. We just need more fresh bodies in here that are practicing good medicine.
Right.
Be that, taking that into consideration, what is our compromise? What is the grand compromise? If we're saying, hey, look, we don't even care why we lost the 25%, is there an argument to revise this law? Or are we saying, hey, it's not the law that's doing it. It's that, why aren't people coming here then? I mean, obviously we articulate our fictitious example with I'll go to Utah versus Idaho. Right. But is that why people aren't coming here? Because my understanding that you're articulating over the last 10 years, the population has grown, the physician population has not grown. And this trigger law went into effect in 2022, which is what we're talking about. So is it that the legislation is bad, or is there something else? Let's say the legislation's like a B- and could be improved to a B or something. I have no idea. But what other things are happening so that my wife and, our mothers and daughters and everything can get healthcare?
Sure. I think the health exception, or whatever you want to call it, the serious emergency medical conditions, serious medical condition, whatever you want to call it, there seems to be some objection to the phrase health exception. So I don't care what you call it. The concept is these really serious pregnancy complications that are not clearly life-threatening in that moment. Being able to intervene on those pregnancy complications, we get consistent feedback that is the number one problem point for physicians who have left the state because of the laws. Almost universally, in the ones that I know of, they've all said, if that was here, we would have stayed.
So, okay. That's one. How do we get more people here?
That's a great question. I think we need to fix the laws. We also, that's another whole aspect of what I'm involved in physician leadership in the state is physician education. So interesting fact about Idaho, we have we educate 200-ish medical students a year. And my graduate medical or my medical education colleagues that might be watching this are probably fainting at my vague numbers. And I apologize to them. But 200-ish medical students we are educating every year, graduating. We have less than 100 graduate residency spots. So in medicine, you do medical school for 4 years, and then you have to do a residency, which is between 3 and 7 years, depending on the specialty. Idaho has some spots, but they're not as many as we have medical students, as we're graduating medical students. And the data,
so these people have to leave no matter what.
So our students have to leave the state to go.
50% of the people that we're educating.
And then we're also not drawing in doctors in training to because there just aren't spots. I mean, we draw some in, and the data on that, the proportion of physicians that stay near where they did their residency training is very high. And so if you kind of a pipeline for getting physicians in a location is having residency training programs. And then for OBGYN, there is no OBGYN residency program in the state of Idaho. We have family medicine, we have internal medicine, we have psychiatry, we have pediatrics. And again, to my medical education colleagues, if I missed one, I apologize. And we have some fellowships, but we don't have OBGYN as an example.
So we're relying on out-of-state residencies and internships to produce these people. And then we, just by the nature of our education system, have to entice them into the state.
Right.
We don't even have a place where it's like a gal goes to, or a guy goes to Eagle High School and then goes to college at, BSU and is like, hey, I want to become an OBGYN and stay in my home state of Idaho. They're like, great, come back in 10 years.
Right. We hope you do.
We hope you do.
Please come back.
We'll still be here.
Well, we will still, the women of Idaho will still be here, and they still need care, and their unborn babies. And we're the people who do that.
So with regard to fixing the law, it sounds like what you are saying is, okay, look, to fix this law, to fix it in, Dr. Kasper's world is, all right, you have life of the mother, fantastic. You have rape and incest, fantastic. You have then health and welfare of the mother with very specifically defined restrictions, not something just a blanket turn health and welfare where it's like she had a headache and she's not happy about it.
Right.
But like these 15 things that we consider health and welfare on a level that justifies this medical intervention. I feel like we could just list those out, couldn't we? And then just everybody vote. They're like, what about this one? What about this one? Like, what about, and then just, because every time I talk to somebody, they're like, oh, you just want, like somebody has a toothache. It's like, that's not reality. Like it sounds like there's a very specific set number of things that could become themselves life-threatening, and they're trying to head them off. Yeah.
The problem that you get into when you're asking for a list is, what if you miss, what if what if something comes up that's not on that list?
Well, none of it's on the list right now.
Well, right. So, and that's a fair point. Potentially a list would be better than nothing, right?
Yeah. Could we set up a review board or something that it's like, okay, and the review board is elected or appointed by the governor, right? So it's like we have a review, we have this base list that everybody, agrees like, okay, fine, we'll take these 4 things. And then we have a medical review committee appointed by the governor that then goes through and articulates whether to include and, I don't know how the mechanisms of government work. I'm just saying like there should be some kind of like living medical committee that's like, hey, we consistently review. Like a lot of things in medicine are constantly turning and changing and getting reviewed and like the application of medications, the procedures with like all of this stuff changes all the time. So it's like, let's just get a couple that we all agree on and then have a review committee that throws out the headache and the toothache and is like, oh, but this is one that like seems to be unique off of this list.
Yeah. The problem with that is that medical science is constantly changing. And so, how do you, once you put something in law, right? So, our medical technology is constantly changing. Like, so I hear that and I'm like, yeah, but then now I don't have any opportunity to say, okay, but this situation is, there's these other variables and now this situation is a problem. Or, hey, our medical technology has changed and what used to be on this life-threatening list, like maybe that shouldn't be on that list anymore. Or maybe it should, but with certain caveats, like and going back again to these things that we're talking about, these pregnancy complications, that we want to be able to intervene on, these are the really difficult situations, right? These are not the run-of-the-mill, like you're having a miscarriage, this is how we treat miscarriage, right? These are unique, complicated problems. And it gives me heartburn thinking about trying to put that into a list that would be replicatable. I think you have a valid point. Would it, be better than what we have now? Well, that's not, it's kind of a low bar in terms of being better than what we have now.
But what I worry about is, look, the people of Idaho that I've heard from do not want the possibility of a health and welfare exemption being utilized in a functional manner to produce elective abortions, right? So it's like, okay, I heard you lot, and like, that's totally fine. Like, I think the people of Idaho should be allowed to vote for these things, elect people who say they're going to, like, I think those sentiments should be honored. What I'm worried about, the only thing I'm worried about, is how we get more OBGYNs into the state of Idaho to care for our women. That's it. And so from my standpoint, it's like, okay, the people of Idaho do not want this thing. How do we honor that and honor and what the practitioners that we need in this state? They need to voluntarily come here. We are not producing them And we cannot force them to come here, and we can't make them stay out of retirement longer than they will. Like, we can't do any of that stuff. So we have to create an environment where they feel they're like, this is my best option. Idaho has to be their best option for a number of reasons. It has to be the best option with pay, with education for their children, with healthcare, all of these different things, right?
Yeah.
And it's like, okay, can you tell me the one thing that you feel like we should add to this list? It's like, can we just, and we get all the way from, preeclampsia. I don't know if I pronounced that correctly, but we go all the way from preeclampsia down to the headache person. And we assess all of these things. Everybody agrees on a chunk. And then you have people that on a regular basis look at applications or considerations or reviews or studies or whatever based on, again, we have a game of probability, right? Like boom, boom, boom. And then you have specialized cases, things of that nature. I don't know. Like I don't live in this world, but it's just like, there has to be a way where you're saying, hey, this law has left out some stuff. Okay, let's write down what it left out. And let's take this to people and say, you left this out and that's wrong because of this. And I don't think the headache case is going to make it. I think there are plenty of real cases that would give the people of Idaho comfort that they're like, okay, they're not doing a runaround on us. Right. Our wishes are being honored. And we have created an environment now where OBGYNs voluntarily come to live, to work, and to raise families.
Or you could define what a serious health condition is. Right.
Isn't that part of the list? Wasn't that the list?
Yeah, but that's a list. It's not a definition. Right.
I see what you're saying.
So you can also say something like, or a serious health condition that if left untreated could result in loss of a limb or loss of a major bodily function.
Here's a question for you.
A headache doesn't do that.
No. Headache doesn't do that.
Nor does a head cold. Right.
Toothache, the whole thing. Is there, if we said that, if we went with the definition that something could lead to it, wouldn't it be prudent to then put some kind of like time fence on that? It's like, it would lead to this within the next 4 weeks. Because what I've heard from other people is they're like, well, all of this could lead to bad stuff down the road. Now, mind you, I don't know anything about it, but that's the exception, which is the reason that some people favor life of the mother is like, we know conclusively right now something really, really bad is going to happen, or we know with a high probability. And just saying like, okay, this is the problem. This could lead to something really, really bad down the road. It's like, again, I know a lot of people that I've spoken with that bring the exception of, yeah, but what if it doesn't? You don't know. Like, you don't know.
So the problem with that, even with your list of conditions,
right?
You don't ever know. I mean, so trying to
flush this out,
the whole concept of trying to get me to tell you.
I'm not trying to back you into the corner, by the way. I'm just trying to figure out, like,
I'm not saying you.
Okay.
I'm saying, anyone. The whole point, the whole problem with trying to get me to tell you with 100% certainty. Yeah. Going back to the none of this is completely black and white. And so it is what it is. And none of us have the power to make it not be that. It doesn't matter how many laws we write. It doesn't matter how many laws we rewrite. It doesn't matter how many laws we take off the books. It doesn't matter how many signs we post. None of us has the power to make the human body and the disease process any less complicated than it is. We can't do that. So if that's our goal, we're just going to be endlessly frustrated. And I would submit that the goal should be that we passionately pursue the safety and the lives, the health of our mothers and of our children. And doing both of those things is an endlessly challenging but rewarding process. And sometimes it sucks. I'm here to tell you as a doctor, sometimes the pursuit of that absolutely sucks. But all we can do is show up and do our best to navigate a human body, two human bodies, along with a disease process that are more complex than we can ever fully understand. And if we're going to be successful, we have to have laws that back us up. And if we don't, ultimately, it's not the physicians of Idaho who will suffer, right? It is the women and children of Idaho who will suffer. And by definition, if the women and children of Idaho suffer, the whole state suffers. Because they are at the core of what makes a society stable and prosperous. So we got to decide.
Dr. Kasper, thank you for coming in today. I would I would love to have another conversation with you and keep going, especially as we go into the legislative session. Again, I'm learning as I go, and I really appreciate your time today.
Thank you. Thank you for having me.